really focus on the subject of the inequitable access to psychological therapies. And I begin by pointing out that psychological therapies are the most effective interventions for a whole range of mental health problems, including mood and anxiety problems, child and adolescent mental health problems, several kinds of substance use problems, and as adjuncts to pharmacotherapy for people with serious mental health problems. One of the conditions for which they are most widely advocated are mood disorders, for which there is also, of course, a competitor intervention, which is antidepressant medication. Head-to-head comparisons of these two interventions typically show that they're both equally good. That is to say, the same proportions of people remit. However, a couple of months ago, this extremely important paper was published that really examined what should be the initial treatment choice, where the outcome wasn't just remission, but staying well, which I think we could all agree is an incredibly important outcome for a chronic relapsing condition that depression can occasionally be. And these authors used a very sophisticated form of meta-analysis called a network meta-analysis. I encourage you to go look at this paper in World of Psychiatry, but I want to just summarize the main conclusion of these authors, and I've underlined it. Patients and their therapists may be well advised to seriously consider psychotherapies, predominantly CBT and BA, as the initial treatment choices for depression. And of course, their last sentence speaks for itself. So here we have it. Psychotherapies, particularly those derived from CBT, should be the first choice for the treatment of the most burdensome and the most common mental health condition in the world. Yet, the real challenge is that in spite of this finding, and indeed the knowledge we've had for more than a few decades now across many other mental health conditions, virtually no individual, particularly in the low and middle income parts of the world, and indeed also in low resource parts of the wealthy world, are able to access psychological treatments. Let me describe the crisis that we're facing, in particular in the US, which has the highest per capita density of mental health professionals, including clinical psychologists, counseling psychologists, and a range of other providers who you would expect would be skilled to provide psychological therapies. And I'm only going to focus on depression. Less than 1/3 of adults with depression receive any treatment in the US, with the largest gaps being, as we heard from the previous speaker, amongst racial and ethnic minority groups. And this is just receiving any treatment at all. And amongst those who do receive treatment, the 1/3 who do, nearly 90% are only prescribed medication, while only about a quarter would receive psychological treatment. So you can do the math. A quarter of a third of Americans with depression receive psychological treatments. That's a fabulously small proportion for what is now we know should be the initial treatment choice for depression. And this is in spite of the fact that patients overwhelmingly express a preference for psychological treatments. And we know that patients who receive their preferred treatment option not only have higher levels of satisfaction, but also enjoy better clinical outcomes. Racial and ethnic minority groups are significantly more likely to want psychological treatments and significantly less likely to receive psychological treatments. Now, this is for me, probably the single biggest crisis in medicine. Imagine if we had to present these data, say, for two options of treatment of breast cancer, and you found that option A was superior to option B, but only a minority of women with breast cancer actually got option A. You can imagine that this would become the single most important issue to address in healthcare. But we see absolutely no such urgency, not even a real recognition that there is this incredible crisis where the most effective intervention for the most common mental health problem is not accessible to the vast majority of people worldwide. What are the challenges? Well, there are many different reasons. Amongst those include professional hierarchies, the dominance of psychiatry with its focus on medication over the non-medication mental health professional groups, the fact that there is professional resistance often within the psychological guilds and professional societies to the empowerment of non-psychologists to deliver psychological treatments, the cultural relativism argument that psychological therapies largely were developed through science that was based in very rarefied, predominantly white populations in North America and Europe, and these theories may not be generalizable to other populations in diverse contexts. Of course, a key thing is that psychotherapy isn't a pill. I mean, if it was, it would be the single most prescribed pill in the world. There is no one commercially backing psychological therapy, so these remain largely the domain of academic psychologists in university settings who are really very good at the science, but really don't have any personal interest in the scaling up, which requires a very particular approach that is outside academia. And of course, the emphasis on only certain cadres of providers often means very expensive training and supervision approaches, which effectively put psychological therapies out of reach to the vast majority of people. So what's the opportunity? Well, the opportunity comes from global mental health, and this being the session on health equity, I need to emphasize that global mental health as a discipline of global health is an area of study, research, and practice that puts emphasis on achieving equity for mental health for all people worldwide. And a key component of that is access to good quality mental health care, regardless of where you live or what your station in life is. While there's a long history that leads to the emergence of global mental health, a key milestone was in 2007 when the Lancet Medical Journal devoted 6 articles on the subject of global mental health, focusing on the large inequities in access to good quality care, and ended with a call to action to scale up the coverage of services for mental health problems, particularly in low-income populations, based on the principles of cost effectiveness and the strengthening of the human rights of people with mental health conditions. Some years later, the NIMH in the US launched the Grand Challenges in Global Mental Health initiative that I co-chaired, which sought to identify the leading research priorities, which, if addressed, could shift the needle on the global burden on mental health conditions, which of course, I'm sure you all know, has not in fact declined anywhere in the world. If anything, all the metrics are getting worse in spite of the fact that in countries like the US, we spend more on mental health care than virtually any other health condition and enjoy more mental health human resources than any other country in the world. The leading challenges were not discovery science, discovering a new gene or a molecule. They were implementation questions. How can we do better with the knowledge we already have? Nearly $1 billion or more of new money has been invested since 2011. And today, with more than 100 randomized controlled trials that have now been conducted in more than 40 countries, examining innovative approaches to delivering mental health care in the least resourced context of the world, I can safely tell you that we now know how to deliver clinical and preventive interventions, almost all of which are psychosocial, in any resource setting, including the one that you see on this image of Zimbabwe, a country with 11 psychiatrists and a few dozen other mental health professionals with 12 million people to serve. In this model of care, the woman on the right, a grandmother from the local community, has been trained to deliver problem solving based on CBT. And the woman on the left is a mother with depression who's been referred by the primary health center nurse, and you can see the primary health center in the building behind, to receive this 6-session psychotherapy under a tree on a bench called the Friendship Bench. My own work has largely been in India, where working with Sangat, we have pioneered a whole range of different psychosocial interventions for a whole range of mental health issues, from the prevention of mental health problems in school settings, to the support of people with chronic schizophrenia, to the standalone psychological treatments of depression and drinking problems, parent interventions for autism, and so on. This large body of evidence really helps us summarize the design principles for these psychosocial and psychological interventions. Typically, these comprise active ingredients that are drawn from both the global evidence of psychological treatments as well as contextual evidence on what people in those contexts do to support themselves in the recovery process. The focus is on active, mechanistically informed ingredients rather than complex multi-component packages. The sessions are very few, rarely more than 6 sessions and almost never more than 10, so that you can get the biggest bang for your buck in the least amount of time and resource use. Training doesn't require you to know all the theoretical concepts. The focus on training is based on competencies, and experts have a smaller role than in traditional models, with an emphasis on quality assurance through peer supervision. This is redefining mental health care in four important ways. Redefining the content of psychological interventions, as I said, focusing on simple, active ingredient approaches, oftentimes also addressing social determinants. Delivering care where people are, such as in my own work, even in the homes of individuals. Delivering care by people who are widely available in the local community, such as nurses, peer support workers, and community health workers. And ensuring that this community expanded model of care is bolted on to the mental health care system so that one size does not fit all and everyone gets the care that they need, the hallmark of person-centered care. This evidence is transforming mental health policy and practice globally. From the World Health Organization, these two policy documents published in the last few years, the World Bank, and the national mental health policies of countries like India, embracing the notion that mental health care, the foundation of mental health care, and the reduction of mental health inequities must lie on a community-based foundation of the delivery of psychosocial interventions for prevention and recovery. That is the focus at the base of the pyramid. There's also increasing recognition now in wealthy countries like the US that this model of care has great potential in countries like the US, where there are very large unmet needs for care. The RAND Corporation, a leading US think tank, produced this important report a few months ago. It's a landscape analysis reporting really in a blunt way that the US mental health care system is failing. And it isn't failing necessarily because it isn't investing enough, because the US already invests more than any other country in the world. In fact, just as a way of comparison, there are more mental health professionals in New York City than the whole of sub-Saharan Africa, from Cairo to Cape Town. And what they recommend is that there is the need to train non-specialists, not only because this will expand the footprint of care, but enable specialists to work at the top of their license. Thankfully, there's also now money flowing. Summit is an example of a large randomized controlled trial funded by the Federal PCORI initiative, which is comparing two different models of care, the non-specialist versus a specialist care model, delivering a brief behavioral activation treatment for perinatal depression. This will be the largest psychotherapy for perinatal populations ever conducted, with nearly 1,400 women participating in 3 North American sites. And we're halfway through the trial now. So I want to end by thinking about the scale up, and I want to share with you an initiative that I have launched at Global Mental Health at Harvard with partners across the US, as well as in many other parts of the world. And that is Empower, a digital solution, not for people to fix their own mental health through self-care apps, but a digital solution that's provider and system facing to empower the massive scale up of frontline workers to learn, master, and deliver quality assured psychological treatments. This is a jigsaw that shows the suite of digital tools that involve the learning of evidence-based psychological treatments. Over many years, we've mastered the methodology to go from an open source manual, for example, of behavioral activation, and convert that into a competency-based learning curriculum. We have also developed a suite of ways of assessing competencies remotely. Once someone completes the training, we're developing digital tools for peer supervision and quality assurance that can help us generate quantifiable quality metrics of therapy sessions. And once credentialed after sufficient case-based learning, you then can then join a growing community of frontline workers who are credentialed to deliver psychological treatments. And as you collect digital data on the quality of their care and link it to patient outcomes, you can begin to see dramatic new opportunities for data science to unpack the active ingredients of psychological therapies and develop novel prediction models for treatment selection and provider training. We started this effort some years ago with the 6-session behavioral activation treatment that we developed in India, the very large randomized controlled trials with patients with severe depression in primary care. These have been replicated, and with NIH support, we developed a fully digitized curriculum for frontline workers to learn how to deliver this treatment, designed validated competency assessments, and we have completed now the largest training trial comparing digital training with old-fashioned in-person expert-led training involving 350 frontline workers, which we will unblind, in fact, on December the 6th. Excitingly, in partnership with the American Psychological Association, I'm delighted the president is with me in this particular session, thanks to the visionary leadership of the APA and also its CEO, Arthur Evans. We have formed a partnership with them and the Meadows Mental Health Policy Institute to translate and to adapt this intervention for delivery in US populations. And I think this might be one of the rare occasions where an intervention, a psychological intervention designed in a developing country, is being adapted for use in a European or North American setting. Usually these adaptation processes occur in the reverse direction. We're delighted that in June this year, we won the Lone Star Prize, a $10 million prize intended for any innovative idea that can transform the life of Texans. And over the next 4 years, in partnership with the University of Texas and the Meadows Mental Health Policy Institute, we will incrementally scale up the community health worker delivered approach for behavioral activation. Simultaneously, we have forged a partnership with the Wellbeing Trust to use the same approach to go even outside and beyond the health sector by developing a wellbeing curriculum that can actually be delivered by coaches or providers in community-based organizations such as child welfare organizations, the police, and so on. This being the ultimate way to democratize psychological science. Ultimately, what Empower seeks to do is to provide a continuous pathway for naive learners to learn new skills and become competent, to then master the delivery of those skills through supervision and become credentialed, and then once individuals start delivering care in the real world, to over time acquire expertise that can then support the next generation of learners. It is only in doing so that we will meet the massive unmet needs for care that have been further increased because of the COVID pandemic. Business as usual will mean that the scale of unmet needs will only grow. What we need is a radical translation of the science of the effectiveness of community health worker delivered brief psychosocial interventions to scale. And to do that, we have to go beyond the orthodox old-fashioned models of in-person workshop-based expert-led training and supervision to employing digital tools to enable us to move forward in a very rapid way. In conclusion, I agree with others who say that the pandemic represents a historic opportunity to invest in mental health care. But I would caution that while we need more money, money alone is not going to solve the problem. Look at the US as a good example of that. We also must make sure that the money is spent wisely, guided by the best science and principles of social justice. And to do that, mental health care must embrace the diversity of experiences and strategies that work. Thank you very much.